Pulmonary embolism, we know that in patients who have defined PEs, massive PE, they go into shock. Thrombolytics are a recommendation by our college to push in the setting of PE and shock. You cannot hang your hat on a negative study, however, because you can actually have a PE and have a totally normal transthoracic cardiac ultrasound. Okay, be very careful there. Don't say, oh, I don't think it's a PE because the heart looks, I didn't see a large RV or RA. It's only when it's positive that it helps you out. And that's true for a lot of things we do in emergency ultrasound. We can rule things in that case. This is a patient who's going to have a massive PE, who's got a very large RA-RV that's approaching or even bigger than the LA-LV. Okay? The apical four chamber is really a great view. I like parasternal long also, thinking in mind that COPD, pulmonary hypertension, that could give you some false positives. This is what it looks like. This was an employee of the hospital who had an external fixation device on his leg, 41-year-old male. He went home after orthopedic surgery. 2 days later, he came back in full-blown cardiac arrest, PEA. We're doing CPR on him, and we saw his heart with no pulse. Now, about 30% of the time, you don't feel a carotid pulse, but you actually see this amount of cardiac activity. So this is called PCM, pulseless cardiac motion. It tells me the patient's still alive, okay? I don't know why they're not having a carotid pulse. It's not enough blood pressure to make a carotid pulse, but about 30% of the time, you will see cardiac activity, organized good cardiac activity like this, yet no carotid pulse. I shouldn't say good cardiac activity. This is very weak cardiac activity. But what do we see here? This is actually trying to be an apical four-chambered view. It's a little bit off to the side. This is the septum of the heart here. We could decrease the depth, but you know, in the heat of the battle, you get what you get. This is the left ventricle. This is the right ventricle. If you look here, it's kind of subtle. It's hard to see, but the RV is actually a little bigger than the LV. So in this clinical setting of an X-fix on this young guy who's in cardiac arrest with a large RV, we pushed thrombolytics, and 2 hours later, the patient was upstairs in the ICU, extubated, eating dinner. And an employee of the hospital, you know, made a big deal and all that stuff. Here's another patient here with a very large, this is the apical four chamber, very large RV. The LV is almost gone. Here's the parasternal long, very big RV, small LV. It's going to go back to the apical. Here's the apical four chamber, big RV, small LV. This is a patient with a massive PE, small LV, big RV. Okay? Here's another patient in cardiac arrest who we thought could have a PE, very large RV, very small LV. We pushed thrombolytics. Guess what? Patient still died.